Hi, my name is Brenna Summa, and today I'm going to be presenting on nurse-to-patient ratios. The first thing we're going to discuss is why this is a problem. Identifying and maintaining the appropriate number and mixture of nursing staff is critical to the delivery of patient quality care. Numerous studies have revealed an association between higher levels of experienced RN staffing and lower rates of adverse patient outcomes. The American Nurses Association supports a legislative model in which the nurses are empowered to create staffing plans specific to their units and their needs. This approach helps establish staffing levels that are flexible, that account for all the adjusting changes within the unit, such as admissions, discharge, transfers, and staff experience and availability. Broken down state by state, currently there are only 14 states that have any kind of law or regulations with nurse-to-patient ratios. The primary state here is California. They're the only state that stipulates a law and regulation requiring a minimum nurse-to-patient ratios that may be maintained at all times. In Massachusetts, they have passed a law specific to ICU patients, maintaining that an RN only have one patient, one-on-one care, or 1 to 2, determined by the stability of that patient. And currently in Minnesota, the chief nursing officer or a designee develops a core staffing plan with input from others. And these requirements are very similar to those in place by the Joint Commission. The bigger picture, Florida right now has no laws or regulations that can help nurse-to-patient ratios. In nursing homes in the state of Florida, they do have some sort of regulation which limits them to how many patients they are able to take, but currently within the hospital setting, there is none in place. Why is this a healthcare issue? First and foremost, the safety of the patients. A large number of patients per nurse was significantly associated with a greater incidence of administration of the wrong medication or the dose or a patient injury with a fall. A study of approximately 232,000 surgical patients in the state of Pennsylvania revealed that about 2% of those, or 4,500, died within 30 days of discharge. The significant study suggests that the difference in the nurse-to-patient ratios of 4 to 1, which is obviously safer, or 8 to 1, may have been a factor in the deaths of those patients. A multivariate analysis of nurse-to-staff patient outcomes reported that when RN staffing is increased, there were significant improvements in patient mortality following a medical or surgical complication. Further data has revealed that the higher staffing was linked to shorter lengths of stay. A shorter length of stay with a resolve in that medical issue is going to cost less for the hospital for those patients to be readmitted with the same diagnosis. When patients are readmitted to the hospital with the same previous diagnosis, the hospital is not going to get paid out for that, especially those Medicare patients. Patient and safety and quality of care go hand in hand. You have to have a good staff mixture. This has to take into account education, preparation of your nurses, experience, those professional needs, all those kinds of factors when addressing nurse-to-patient ratios. Nurse managers need to make assignments based on the competency level of their nursing staff, their critical thinking skills of those staff members, and make that basis on a daily activity for their staff assignments. An effective staffing model should take into account the resources, such as support personnel, having the right amount of equipment, having things readily available to make the nurses' work flow more easy. Setting standards. I have a chart here that indicates ideal patient ratios. So for labor and delivery, the ideal ratio is having 1 nurse to 2 patients. Something like an operating room, 1 nurse should only be in charge of 1 patient. Patients on telemetry, cardiac monitoring, the suggestion is 1 nurse to 4 patients. The safety of the nurse is also going to affect the safety of the patient. So when nurses are taking higher acuity patients, having more of those patients in their responsibility, they're going to become burnt out more. There's going to be a lack of employee retention. People are going to start seeking other opportunities. People are going to become dissatisfied with their job. Poor quality patient care. This is a direct reflection of patient satisfaction scores. And you're going to have more prone to medical errors. So these are all things that relate to patient safety. Currently, in the state of Florida, there is a Senate bill, 1512, related to the Florida Hospital Patient Protection Act, requiring a minimum staffing level of direct care registered nurses. This bill has been in effect since 2010, but it continues to die in Senate. It's not being passed, it's not being promoted. So in order for this bill to get passed into legislature, nurses need to step forward and write bills to their senators to get this act passed. But right now, there is no law. This has not been passed. How can we make a change? Well, non-maleficence involves avoiding harm to a patient. That's our primary goal as nurses. We don't want to harm our patients. We're here to take care of them, help them get better. But in order to adhere to this principle, nurses need a solid foundation. Shorter staffing and the nursing shortage both affect the way in which we're able to make this principle happen. Unfortunately, an unmanageable workload, having more patients than we should, can especially affect this and make nurses more fatigued. It can also cause an abandonment of this principle altogether. While the increasing number of nurses caring for patients does cause a slight change in operating expenses for the hospital, it has a benefit of decreasing the amount of time spent in adverse patient outcomes. A greater number of nurses at the bedside help increase patient satisfaction, improve quality of care, increase nurse morale, satisfaction, and retention. A new beginning. Several studies have shown that increasing the number of RNs does not significantly decrease a hospital's profit. It's going to help promote your unit, it's going to help promote patient safety, and your patients are going to be not coming back with the same admitting diagnosis. You're going to have time to solve those diseases. The change that needs to be made on a national level to increase both the number of nurses able to help practice this setting, able to help practice this and make the nurse-to-patient ratio more realistic. In conclusion, having more staff nurses at the bedside improves the outcomes for both the nurses, the patients, and the organization. Patient safety goes, just like I said, with patient satisfaction. So these are these scores that we're getting back on the hospital level, your HCAP scores that are going to show whether your nurses were doing their job, spending enough time in the room with the patient, educating them on their diagnosis, educating them on their medications, how to get home safely, discharge instructions, all those types of things that we have to spend extra time at the bedside for. When we're caring for more patients than we can, we're not able to elaborate on those things as much as we would like. So all of this stuff is going to go hand in hand. It's a domino effect. The effective increased nurses at the bedside has shown to have a marked change in patient outcomes, especially in California, which is the only state that has these laws in place. So if we can unite within Florida, we can make this happen nationwide. And that is it for my presentation on patient ratios and safety. Thank you.